For the next session on Endo Hepatology, I would request Dr. Hasita Vijayvanta, Dr. Surendra Rana, and Dr. Arka Dey to please chair this session. Dr. Vikram Bhatia will be presenting first because he has a flight.
Good afternoon, everyone. Let's listen to some more about this exciting field of endohepatology. First of all, let me welcome, should DUS guided management be the first choice for gastric varices will be the topic, and may I invite Dr. Vikram Bhatia to enlighten us on that topic.
Thank you, chairpersons, and I would like to thank Dr. Ajay Duseja, Dr. Sunil Taneja, Dr. Arka for organizing one of the best academic conference I have attended so far. And the topic given to me, which I will cover in the next 15 minutes, is should US guided management be the first choice of gastric varices? And well, the answer cannot be a simple yes or no. And what I will present in the next 15 minutes will be much of my own thoughts and views and my interpretation of the existing literature. And I acknowledge that to manage a complex disease like gastric varices, there may be more than one right path, and it is okay to be open and discuss and see what different beliefs are and how we should approach this difficult problem. So the learning objectives of my talk will be: one, to review the endoscopic and vascular anatomy of gastric varices as it applies to us, to understand the IR and endoscopic treatments of gastric varices, and then decide together the appropriate treatment for gastric varix in a given patient. Now, the treatment options for gastric varices are not only US guided endotherapy. Is there a pointer or something? But also the most commonly used is a freehand glue injection. And then obviously there are others like thrombin or gel foam, which I will not discuss because they are temporary clotting agents, and the varices recanalize if you fill up the varices with thrombin or gel foam. Then among the IR we have TIPS and gastric varices embolization. Now remember that the diameter of TIPS is much smaller than the gastrorenal shunt. So if you do a TIPS alone, the GRS shunt will still will be the dominant diverging channel. So TIPS for practical purposes should always be combined by gastric variceal embolization, usually through the left gastric vein. Then we have the retrograde transvenous obliteration, which blocks the outflows like BRTO and its variants like CARTO and PARTO. So this is the classification that we all use, the serine classification, and this is GOV1. The inflow in this varix is through the left gastric vein, and the outflow is through the paraesophageal collaterals. These are most common, 70%, and we may also loosely call them as junctional varices. The treatment for these types of gastric varices is usually in our centers an antegrade glue injection in a non-retroflex position, straight half a cc to 1 cc, or we may band them if they do not extend too far down into the stomach. What is amenable to EUS guided endotherapy are GOV2, which may loosely be called junctional and fundic. And here the inflow is through the short gastrics, the posterior gastrics, possibly also the left gastric, and the outflow is upward into the paraesophageal network and also into the gastrophrenic network down, and lateral into the gastrocaval network. And then the fundic varices, which contribute the 6.7%, these are called IGV1, and the inflow is the same, but the outflow is usually through the gastrorenal or the gastrocaval shunts, and we will not talk of the distal or ectopic. But not all GOV2 and IGV1 are very good for US guided endotherapy. And for my practice, I would like to use the Iwase classification. And this simply divides the cardiofundal varices into two. One is the localized type gastric varices, the Iwase 1, and the other is the diffuse type gastric varices called Iwase 2, or you may just describe it without classifying it. This is the easier one for US. There is usually one or two perforators, and it is a one big ball of varix with usually 1 or 2 cavities, and you puncture, and the whole thing is obliterated. And then you have the Ivase 2, which is diffuse type, and here you have crisscrossing variceal channels. And even if you make one EUS guided puncture, even if you localize the inflow perforators, usually bits and parts of it are left. And I often combine this with freehand glue injection or further EUS injection. So here you have the option of both a endoscopic freehand injection or a EUS guided injection to save cost. The GOV1, as I have mentioned, drains upwards via the gastroesophageal pathways. The GOV2 will drain via both gastroesophageal and the pericardiophrenik system, and the IGV1 will drain via the pericardiovenous system, and this is important to subsequently manage these patients. So let me tell you what pericardiophrenik vein complex is. The pericardial vein comes from where the left subclavian and the internal jugular meet. It descends along the left side of the heart, pierces the diaphragm, and then anastomoses with the transverse part of the inferior phrenic vein. We can see the inferior phrenic vein on US behind the probe when we are just across the G junction above the LGV collaterals, and this goes and drains into the IVC, the lateral aspect, or the anteromedial aspect along the LGV insertion, and we can identify this. And this forms the gastrocaval shunt. The descending part of the inferior phrenic vein drains into the left renal vein, and when this dilates, we call it a gastrorenal shunt. And together, the pericardial and the inferior phrenic vein complex is called the pericardiophrenik vein complex. And this is one of the major drainage outflows. And as you can see, the gastric varices IgV1 in particular can drain not only via the GRS, but can drain up, drain sideways, or drain backwards. And this sort of veins become very important around the posterior and superior aspect of the stomach, where it is the bare area of the stomach, and these can then collateralize or anastomose with the gastric varices at that part. And let us conceptualize the gastric variceal anatomy as a gastric variceal system. This is how the radiologists conceptualize it. You have the false gastric veins and the true gastric varices. The true gastric varices are what we treat endoscopically. The false gastric varices is the cluster that you just see outside the gastric walls, which connect to the true gastric varices by perforators, which take in the inflows through the left gastric, the posterior gastric, and the short gastrics, and which drain out through the pericardiophrenik or the gastrorenal shunt. So the false gastric varices, which you see outside the gastric wall, is where the gastric varices merge, the afferents enter, and the efferents go from. This is what is targeted by the IR people, and we are directing it at the true gastric varices. We do not alter the portal hemodynamics when we treat gastric varices by EUS. Now, this is a TIPS venogram, and there are two runs. Through the TIPS venogram, you see the inflow through the left gastric vein dominant, splenic vein is attenuated. Posterior gastric vein comes out somewhere from between the splenic vein, goes up, and the short gastric veins come from the spleen to the fundal area of the stomach. And then this is the afferent. Further run shows you that the whole variceal complex is draining down through the gastrorenal shunt. The splenic vein thrombosis with left-sided portal hypertension. Now this is a different ball game. This is what happens normally. The short gastric veins drain to the spleen, the gastroepiploic veins drain to the spleen, and then the splenic vein takes the blood back to the splenoportal confluence. The top of the stomach and the left wall drain through the coronary vein or the left gastric to the portal vein and then back up to the liver. Now when the splenic vein is blocked, the short gastric veins become the outflows of the spleen, and the gastroepiploic vein also becomes the outflow. So you have varices, ectopics developing along the greater curve. And this is one situation where the gastric varices develop along the hepatopetal collateral flows, pathways. And this entity is not possible to be treated with IR interventional radiological treatments. During the acute stage, When the patient bleeds, we treat it endoscopically, but the definitive treatment for this category of splenic vein thrombosis, sinisteral portal hypertension who has bled, is surgical splenectomy. So that is a separate category. Let us now move to interventional and radiological and endoscopic treatments. Very briefly, you have BRTO, where you cannulate the GRS shunt from the left gastric vein, occlude it by either a plug or a balloon, and then fill the contrast and the sclerose until it rises up into the variceal complex and thromboses it, or you create a TIPS. So these are fundamentally different. TIPS is creating a new portosystemic shunt, while BRTO is blocking a existing portosystemic shunts. So obviously, conceptually, they are diagonally opposite, and we shall just come why this is important. These are the endoscopic treatments. So we have these glues, which differ by the length of the alkyl chain. As the length of the alkyl chain increases from top to bottom, the histotoxicity decreases and the polymerization time increases. So what we have in India is the 4-alkyl and butyl cyanoacrylate, which has short polymerization time. And you also have 2-octyl, which is 8-alkyl chain, which has 3 to 4 times roughly longer polymerization time. So the flush solution for the octyl glue is saline. Why? Because we want it to polymerize faster. And the flush solution for N-butyl cyanoacrylate is distilled water. Why? Because we want it to polymerize slower. And also, when we read the papers, one must remember that volume by volume, they are not equivalent in efficacy. So 2 cc of N-butyl cyanoacrylate is roughly equivalent to 5 cc of 2-octyl cyanoacrylate. So if we are using the octyl glue, we may want a longer or a larger volume for having the same hemostatic effects. These are practical issues. Dr. Ajay has talked of the coils. Basically, these are alloys with radiating wool fibers, synthetic fibers, which act as scaffoldings for the platelets and for the glue to attach. Now, if the patient is actively bleeding, obviously, we just want to stop the bleeding, and this is where EUS shines. We can look under the blood with a EUS so it doesn't hamper us. Obviously, we have to be very careful to prevent aspiration because the lights are out and we are working in black and white. And personally, I believe that patients who have large gastrorenal shunts have more encephalopathy, are more difficult to wean off because they have higher ammonia levels, but this has never been formally tested. So we don't like to intubate, and we are very careful in doing endoscopy. There is a single IR report of salvage RTO in acute cardiofundal varix from ILBS. There is no other report. 52 patients retrospectively analyzed, in whom endoscopically we failed to control the cardiofundal bleed with good survival, and BRTO could be done, but this is the only one. In general, we will go for EUS or freehand endoscopic injections. What we often encounter is semi-elective treatment of gastric varices. The patient has bled, or we are deciding primary prophylaxis, and he comes to us. And now there is no data which has compared EUS endotherapy with either TIPS or EUS endotherapy with RTO. So I propose, or I think, that we should think of the concept of added benefit. And what is this? So if a patient comes to me, I'll evaluate him clinically. We'll do a CT and we'll do a echocardiography. And now clinically we can divide these patients into 2 groups. It is 12 minutes. I think I had a 15-minute talk. So the patient has PVT or SVT. Patient has ascites or hydrothorax. He has large untreated esophageal varices. His age is not advanced. His MELD is favorable, and his Phipps-Freeburg index is less than 0.92. Now, this patient is amenable to TIPS with ATO, antegrade transvenous obliteration, and he can also be treated by endotherapy. On the other hand, the patient has a favorable anatomy for RTO, has cardiopulmonary contraindication to TIPS, has had HE, is sarcopenic, his MELD is high, his Phipps is high. Obviously, I'm not going to do TIPS, but maybe RTO can help in this patient, and endotherapy is still applicable. So now I have to decide whether I do TIPS or endotherapy, or I do RTO with endotherapy, and then I see the concept of added benefit, whether HE can also be treated, sarcopenia can also be treated by doing a BRTO, which I can't do with EUS endotherapy. So at the last part of my talk, I'll show you 3 papers. This is a recent meta-analysis by D. Mosquita, and Radhika was also part of it, published this year in 2025, of EUS cyanoacrylate plus coil versus endoscopic freehand cyanoacrylate glue. And this showed that there was no difference in systemic embolization, but when we used EUS, there was lower rebleeding and reintervention rates. And this included 6 studies, 4 of which were retrospective. Now, my take on this in such kind of meta-analysis is that in general, different operators were doing EUS and endoscopic treatment, and more skilled operators were doing EUS. So when we show a difference, it is very difficult to decide whether the better outcome in EUS was because of a higher skilled operator or a true benefit of the procedure per se, while the endoscopic treatments were being done by fellows and newer faculty. So we have to keep that inherent bias in mind. In none of these trials, the same operator did both the arms. So that is just my criticism. This is how I approach, this is my view. If the patient has lesser curve or junctional varices, we will do freehand endoscopy. If he has fundal evase 1, I can do either, but I will prefer EUS coil glue. If he has evase 2, I'll do a endoscopic direct injection because I'll need too many needles. If it's a big varix, EUS should be preferred. If the patient has coagulopathy, maybe I'll prefer a EUS injection transcrural. If the patient has active bleeding, EUS, not freehand. And if I know the patient has right to left cardiac shunt or IPVD, maybe I'll use EUS and use coils alone and not put in a glue because to avoid embolization. These are just my ways of looking at patients. And again, this is how I decide. If it's a very small varix, I can puncture it with 22G and use N-butyl. If it is 5 to 10, I can puncture it with 22G, maybe put one coil and glue. If it is 10 to 20 or more than 20, it is a 19G needle. Put in lot of coils, 2 for up to 20 and 2 to 4 for more than 20, and then follow it with glue. So this is how we will approach based on the size. And last 2 slides, this was a comparison of EUS coil and cyanoacrylate versus EUS coil. And they showed that when you combine coil with cyanoacrylate, it was better. And this very nice paper from Dr. Jajaria from SMS, Jaipur, in endoscopy, again this year, RCT from India, EUS coil plus cyanoacrylate plus EUS cyanoacrylate showed that, again, the combination was better than cyanoacrylate alone. So I'll summarize what I have spoken on. During acute gastric variceal bleeding, endoscopic treatment is usually preferred, maybe EUS guided. We should consider the clinical profile, the vascular anatomy on CT, and the gastric variceal morphology and endoscopy before elective GV treatment. And I propose the concept of added benefit and applicability before we decide on elective gastric variceal treatment, because certain treatment modalities can benefit beyond gastric variceal treatment. Bigger varices, active bleed, coagulopathy. These may favor EUS guided endotherapy over endoscopic glue injection. And last, among the EUS guided modalities, the highest clinical success and lowest rebleeding rate is with EUS coil and cyanoacrylate versus EUS with either coil or either cyanoacrylate. Thank you.
Thank you, sir. Thank you, sir, for an excellent lecture on, I think, the anatomy of gastric varices and the role of US in handling it. Please join us. We'll take the questions after the discussion. Also, do you have to leave? Then we will take the questions first. I think sir has to leave. So we take a quick few questions. Sir, please.
Sir, excellent talk as always. I just wanted to know which set of patient of gastric varices would you straight away refer to IR for a RTO, BRTO, or its variants?
So again, obviously I said that if the patient is amenable or can be treatable by RTO, most of these patients are also treated by EUS endotherapy. And now it is not that I want to do EUS endotherapy, therefore I will choose that. One has to be patient-centric, and hence the concept of added benefit. If this patient has had episodes of HE, and is otherwise applicable, or maybe is sarcopenic, or his liver volume is low and I want to increase the portal side blood flow, maybe I will send him to a, a BRTO, because that also simultaneously takes care of the shunt related encephalopathy. Otherwise, it's a matter of what is applicable and what we want to do.
Dr. Narendra, please.
Dr. Vikram, hi. Thanks. That was great.
And
So, gastric varices more than 2 centimeter at short axis. Currently, we are not placing coils because coil upper size is 2 centimeter, and we fear for embolization. Any comment on that?
I don't think the coils usually will blow off. So they very scarily sort of twirl and move when we put in coils and we feel they are going to blow off. But then mostly we keep the needle in and the coil is twirling around our needle, and we pass a second coil and then they get entangled, and maybe a third coil. So in practice, I don't think it is very common that we deploy a coil and it flows away in front of us. It just twirls very scarily in the varix, but that's it. It doesn't go off. And in practice, I don't care about 120%, 150%. My rule of thumb is if the varix is whatever the size of the varix, plus 1 centimeter is for me. Because it is impossible to calculate 120% of the varix size when you have the needle in, and nobody can do that kind of calculation in the brain at that time.
Thank you.
Thank you, sir. Any other questions?
One more question from me.
Please.
What about now we see patients who coming with post glue injection deep ulceration. So do you have any experience of managing deep ulcers with EUS guided therapy afterwards?
So deep ulcers after gastric variceal glue injection usually reflect a extra variceal intramural injections, and then the glue can lead to a lot of necrosis of the gastric wall. It means that the original injection was not accurately placed intravariceally. Having said that, it often happens with all of us, is not uncommon. And when these patients bleed, it can be very difficult. So yes, this is another situation where EUS will help you, because what you can, patient is finally bleeding from the incompletely obturated varix underneath it. So we can still find out the patent channels and make injections there. And this is one situation where further blind injections into what you think is the patent varix may actually worsen this situation. So yes, I agree, I didn't cover it. This is another good application for EUS.
I think for want of time, we will stop the session, and we invite
Thank you.
Dr. Narendra for the next session on US liver biopsy and US PPG. Sir is the Associate Director of Department of Gastroenterology and Hepatology at Medanta.
Thank you, Arka. So, how needles evolved in this time? It was simple FNA needles initially, then reverse bevel, Procore, fork tip, then francine. There is a better tissue yield with francine. I will discuss that later. What are advantages of EUS guided liver biopsy? Focus sampling can be done. We can target left lobe also, right also. It is not correct that IR guided left lobe biopsy cannot be done. Of course, IR can guide both lobes, and we can also. We can simultaneously measure portal pressure. We can look for varices. We can do therapy for varices also. And for obese patients, where there is significant distance from skin to liver, percutaneous becomes little difficult. There is a crowding of ribs, then percutaneous becomes little difficult. So it can be done in those patients also. Gradually, the technique evolved. So landmark studies in this aspect: suction versus no suction, wet suction is better, probably by decreasing fragmentation of biopsy. Capillary action versus suction, suction is better. How many needle passes and actuations? So one needle pass and then 3 different actuations. Within that, one pass is better than one pass and one actuation. Size of needle 19G is better than 22G. And 19G francine is better than 19G FNA. So FNAB needles are better than FNA needles. And out of FNB needles, this francine is better than fork tip. So this gradually this technique evolved to 1 pass 3 actuation, 19G FNA, VAT suction. So this is what we do. We can see we are inside liver. Then we will make 3 passes. We go approximately 4 centimeter deep. We pull it gradually. Once we are near capsule, again we will make a pass in slightly different direction. So after 1 pass 3 actuations, we withdraw needle gradually, but we are still inside liver, and we place Doppler to look if there is continuous blood flow in needle tract. If the blood flow doesn't cease after several minutes, then we can sacrifice the tissue we have taken by pushing stylet again. If we fear bleed in tract, we can place gel form also. We never required that. This is image from a percutaneous biopsy. But yes, it can be done by this EUS guided, but we need to sacrifice tissue. Tissue handling, we use this sieve. If all the tissue is placed after flushing, it will be lot of blood. So this sieve, it filters blood, and we can select good tissue fragments, and we can leave clots. It comes approximately 4,800 rupees one time investment, and we can use it for every biopsy later on. What are ASLD recommendations? So these recommendations are old. 2000, it is 2009, not 99. 16G needle. EUS needle is 19G, and if cirrhosis is suspected, then a cutting needle is better than a suction needle. So one of the possible limitations of EUS guided liver biopsy is thinner size of needle, and a whole nodule may not come, and F4 may be labeled as F3. Adverse events, 9 studies, 437 patients, pooled rate insufficient specimen was 10%. This is old study. Now it must be less. Pooled adverse events, it is 2.3%, bleed 1.2%. It is similar to what we see with percutaneous biopsy. EUS versus percutaneous liver biopsy, this is older meta-analysis. At this time, percutaneous was superior in terms of mean number of complete portal tracts and specimen length. With two latest meta-analysis, 4 RCTs, EUS biopsy group, lower pain. Diagnostic accuracy is similar. Number of everything is similar other than longest unbroken specimen, that is more with percutaneous biopsy. What are extra advantages of using EUS over percutaneous method? So portal pressure can be measured, but if there are collaterals, platelets are less, then already this is CSPH, and we may not use portal pressure gradient measurement. Also other organs can be evaluated. Lymph node FNA can be taken if lymph nodes are there. There are some limitations of endoscopic ultrasound. This is a commentary. So in obese, and if there is some ascites not on gastric side, then EUS is preferable. But if we require several passes, like we fear for inadequate tissue, then percutaneous biopsy is better because it can be plugged and several passes can be taken through a sheath. EUS doesn't provide us option of several tissues, several passes through one simple puncture. So when to do EUS biopsy and not percutaneous biopsy? At present it is costly. If we can compensate this cost with some other procedure, or like EUS is recommended for some other procedure, then cost becomes equal. A classical example is evaluation of cholestasis. We look for biliary system, and when no biliary obstruction, we think of intrahepatic cholestasis and take a biopsy. When we need a lymph node sampling, when concomitant endotherapy is planned, then or pain is of course less, but sedation is required. Portal pressure gradient measurement. So portal hypertension is associated with all complications and including variceal bleeding. It has both therapeutic and prognostic implications. Portal pressure gradient is hepatic vein or IVC pressure and portal vein pressure. So this is decreased from portal vein pressure. More than 5 is portal hypertension. More than 10 millimeter mercury is clinically significant portal hypertension. When we require PPG measurement, so before surgery, to know risk of surgery, because patients with CSPH will have higher risk of post-op mortality and morbidity. A classical example is patients with CLD and CKD and requiring kidney transplantation, compensated CLD, where we want to know what is HVPG. Another classical example is bariatric surgery in compensated CLD. Why EUS guided portal pressure gradient over HVPG that we are doing for many years? So in HVPG measurement, there is radiation exposure, use of IV contrast is required, and it is indirect measure of portal vein pressure, but it is good, it correlates with clinical status. What is technique? 25G FNA needle, and this manometer, it comes with needle, and we use heparinized saline. This manometer is attached to needle. It is 25G EcoTip inside. It is currently not available in India. It is by Cook. It is kept at mid-axillary line. Patient in supine position, anesthesia. First, we measure hepatic venous pressure. So we can see this needle inside hepatic vein. Once we are inside, we flush it. It takes some time for a stable value, 30-40 seconds. Then we record it. We again flush. Again, we take a recording. So total 3 recordings are made. After every recording, we flush with heparinized saline. It takes 30 to 60 seconds for a stable reading. Three readings for portal pressure, 3 readings for hepatic venous pressure. Same for portal pressure, left portal vein is punctured. There are variations. Some of studies have used 22G needle in place of 25G needle. And if a stable, a significant diameter part of hepatic vein is not visible, then we can puncture this intrahepatic part of IVC or intrahepatic part of portal vein rather than a portal vein radical. How to identify vessels? Sorry. Hepatic veins, it appears that they have no walls because walls is very thin. Portal radicals are thick walled. We can see IVC here, and this is portal vein. If we follow this IVC, we can see hepatic veins. This is ligament, this white band is ligamentum venosum. We can see a hepatic vein beautifully here and a portal vein radical here. If some confusion, we can use Doppler. This is left lobe of liver examination, segment 2, segment 3. This is left hepatic vein and a portal vein radical. In doubt, we can use Doppler. So we have placed this Doppler on portal vein radical and we can see a monotonous flow. If we place this Doppler on hepatic vein, it will be triple phase because of atrial contraction, ventricular contraction, and atrial relaxation. Portal pressure gradient will be mean portal pressure minus mean hepatic vein pressure. Does it correlate with what is safety? So it was first such study, 28 patients, 100% technical success and no adverse events. Subsequently, several studies, technical success is excellent, 100%, 91%, 100%, 100%, 91, 98. Adverse events are uncommon. Does it correlate with HVPG? 9 patients, 22G needle, IVC and portal vein were punctured. So correlation was 0.92. It is excellent correlation. Some other studies are also there that have shown correlation of one is 0.74, ARCA has a presidential poster in this meeting. It was 0.8 with clinical status. Systematic review of EUS guided portal pressure gradient measurement, 8 studies, 178 patients, 94% technical success. Clinical success is correlation with clinical status of patients with this PPG value, 85%. Adverse events, 10%, but mainly mild. It is pain mainly. Bleeding is 3.6%. No cases of perforation or death. One hematoma managed conservatively. Comparison of EUS guided PPG with IR HVPG. So at present, cost for EUS PPG is more if that EUS FN needle is used. Cost is less with IR guided HVPG. Adverse events, both modalities are safe. Comfort is better because we use sedation. IR guided HVPG, we can do TGLB also, but for we can do biopsy, EUS guided biopsy. We can do gastric varices therapy also if there are. Propofol decreases HVPG by approximately 1 millimeter mercury that we need to see. Cost is elephant in the room at present for EUS guided procedures. For EUS guided biopsy, this is US study 1800 for percutaneous versus 3200 for EUS guided biopsy. In Medanta, cost is approximately 35,000 Indian currency versus 65,000 for EUS guided. EUS guided HVPG, we don't have this needle, but this needle is available in Asia Pacific. Cost is 1.25 lakhs for EUS needle. At Medanta, HVPG is 35,000. So EUS will be costly unless we use indigenous methods like ARCA described. HVPG and TGLB in Medanta is approximately 1.25 lakhs. So if we are doing both, then it is equal. Also, one advantage in government hospitals, because few IR persons, busier IR department, so rather than waiting for few days for IR guided HVPG, they can do EUS guided PPG. I conclude EUS liver biopsy is sort of well established now. For portal pressure gradient, there are fewer indications than biopsy. Adverse event profile is okay. Cost is main issue at present. If EUS is being done for some other thing, then it cost becomes similar. Thank you.
Thank you, sir, for an excellent lecture. Please join us for the discussion.
Sir, as usual, great presentation. I have two queries. What would be the indications to do a dual lobe biopsy? In most of the time, percutaneous, we are actually doing right, and for US, the easier access would be left lobe. So when would you say to do dual lobe biopsy, and how easy it is to do a right lobe biopsy with the US, because you have to go to the duodenum, and it's far more easier a left lobe from the stomach.
This is a wrong notion that percutaneous biopsy cannot be done from left lobe. This is wrong. IR guided persons are doing for many years. They are happier in left lobe biopsy than right because they don't cross pleura there. EUS guided right lobe biopsy is slightly difficult, but can be done. Indications of biopsy from both lobes, it is very rare. Sometimes we do in donors where we fear for fat, where MRPDF shows that right lobe is more fatty than left, or it is otherwise. Less than 1% biopsies are from dual lobe. It is not an advantage of US guided biopsy.
Akash, just before you give, I'll just make one comment. It's about the cost. I think it will depend a lot on the setup. So in our setup, US guided things would be much cheaper as compared to, I'm not talking about percutaneous liver biopsy here, but as compared to say a TGLB or HVPG, it would be much cheaper. So using the indigenous setup of measuring the PPG, it's basically the cost of a US FN needle. So that's around 22, 24,000 rupees as compared to the HVPG balloon that itself is around 40, 50,000. And then if you're going to do a TGLB plus HVPG, so just the cost of the equipment comes around to be almost 1 lakh. And then the date issues and etc. So I really think it's not a game of one-upmanship. Who does it, etc. It doesn't matter. Ultimately, we are treating a patient, and the decision as to what route to do, it's got to be individualized depending upon different factors. Akash, please.
Just one thing which I think we have not hit about. We're talking about cirrhotic and sinusoidal portal hypertension. I think one of the areas where the applications become more important is pre-sinusoidal portal hypertension, PSVDs, non-cirrhotic portal hypertension. So that's an area where actually it might definitely overscore an HVPG. Sedation, as you mentioned, is a problem. With propofol, the effects
It
of
decreases by 1 to 2
yeah,
millimeter
and with
mercury.
these short variations, a 1 to 2 millimeter difference is very significant. Last part is every study talks about correlation. These are two metrics which are looking at the same thing. It's like you measure height by centimeters and meters. They will correlate, definitely they'll correlate. But I don't see data about levels of agreement. Outliers are there, and what are the responsible features for the outliers? So no levels of agreement, low bland
So
advance.
sometimes in HVPG there are veno-venous shunts
Yes.
that decreases HVPG, but it will not decrease EUSPPG. But a radiologist can identify that by injecting contrast. That is one condition where HVPG is falsely low. So there is a presidential poster by ARCA, approximately 150 US guided liver biopsies and 28 patients where it is EUSLB and PPG. Congratulations for that.
So Arkasab, you have looked at the levels of agreement beyond correlation.
Well,
No.
that's not been set out, but you're correct. I think what you need is a bland Altman analysis. If you're trying to
I,
replace a procedure with another procedure, we need a bland Altman analysis, and
so
definitely not
So
correlations.
comparing HVPG and PPG becomes ethical issue because for same patient we are doing two procedures, but some of studies have done that. So most of studies they have looked at clinical status. Like it is non-cirrhosis, EUS PPG is less. It is cirrhosis, EUS PPG is high. So most of persons have looked at clinical correlation rather than with HVPG.
Sir, my question is for Narendra sir.
Yeah.
Sir, in one of the study you quoted, you mentioned about technical success and also clinical success. Could you
So
clarify the clinical
okay,
success?
so technical success is getting good values, almost similar values three times from portal vein radical and HV. Clinical success is they looked at clinical status of patient, like there is CSPH already, there is cirrhosis already, there is no cirrhosis that ARCA has done, that PPG is less in patients with F1, F2 as compared to F4. So that is clinical success.
One question to both of you. So, from a point of view of a person who is coming from resource poor setting, have you ever reused these needles? Because cost seems to be one of the limiting factors.
Yes, we have used that decreases cost, and like in Medanta, it is HVPG plus TGLB is 1.25 lakhs. But when we request them to reuse, cost decreases to 40,000 only for IR guided HVPG and TGLB. So yes, of course we can, and we use. Not always, but yes, we use for poor patients.
We also reuse. So before we end the session, just one last question. We always talk about the adequacy of the tissue that we get and the ASLD criteria and all these criteria. And so there's evidence to show that FNA needles have got less diagnostic yield as compared to the FNB. And that's on the basis of CPTs and the length of the core.
Yes.
But still, if you look at that study, the length of the core is almost 18 centimeters. The number of CPTs that's present is 18 or 20, something like that. So can we really call that inadequate? Why I'm asking this question is that in a non-cirrhotic patient, I personally feel that an FNA needle performs, I mean, the diagnostic yield is adequate, and then it decreases the cost by a huge thing, 24,000 by say 40,000, 45,000. So it decreases the cost by a huge thing.
I believe if we don't suspect cirrhosis, then we can use FNA. If we suspect cirrhosis, then FNB, or maybe it is then percutaneous rather than FNB.
Yeah.
So there is a DNB study ongoing in explants where we are comparing EUS FNAB versus percutaneous. Approximately 8% difference in. So some of F4 are classified as F3 by EUS.
So I think if there are no final comments, we close the session. Thank you, sir, for an excellent session, and we move on to endohepatology session 3.
Thank you.